Good afternoon, everybody. Thank you so much for joining us for today's webinar. William Osler Health System, first acute care hospital worldwide to implement the butterfly approach to dementia care, co-hosted by CARP Ottawa. My name is Taeyang Zhang. I am the event and project manager at Family Council Ontario, and today's guest speaker is Dr. Nadkarni, who will be introduced by my co-host, Carol Duke from CARP following my introduction. So before we start, I would like to take a moment to recognize the land on which we are gathered today. I'm currently in Toronto, which is seated on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis people. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. We wanted to share a few logistics and housekeeping rules before we turn things over to our co-host. First, I would like to pull up this poll with a few questions for us to know our participants and where you are attending this webinar. And you can answer it during the introduction part. I will leave it up. Thank you. So you will also notice that everybody is in listen-only mode. That is because we have reserved time today at the end for an interactive question and answer period. At that time, we invite you to use the Q&A box to ask your questions to our guest speaker. Margaret from CARP will facilitate the Q&A session. You're also welcome to leave your question in the Q&A box throughout the presentation, and they will be addressed at the end. And if you're experiencing any technical difficulties or logistic questions, you are welcome to use the chat feature and I will respond there. And as you may have noticed, today's webinar is being recorded and it will be made available on Family Council's Ontario YouTube channel next week. So now it's my pleasure to turn things over to our co-host Carol from CARP.
Thank you for joining us. The CARP Ottawa group is very interested in long-term care and have been advocating for quite some time that everybody uses a person-centered, emotion-centered care in order to look after seniors that live in long-term care. So we were really excited to hear that primary care was actually going to be doing this as well. There's such a jump between the transition when a person moves from a hospital or home into long-term care. The fact that that whole genre of being able to be supported is being started in the acute care setting is really quite interesting to hear and exciting. So our guest today is going to introduce how that's happened and help us walk through it and understand it. Dr. Nadkarni is currently serving as the clinical coordinator, program coordinator at Senior Health Rehabilitation in the complex continuing care and transitional care in Osler. He has been able to be trained as a family physician and has a master's degree in health science administration from the Dallas University. Dr. Nadkarni's career is marked by contributions to novel healthcare initiatives, which includes supporting the butterfly model of care. This model for dementia care emphasizes compassion, patient-centered care, and sees emotional well-being as an important part of physical health. Dr. Nadkarni's leadership has been instrumental in driving quality improvement initiatives. He is a recipient of a number of awards, including most recently the Canadian College of Health Leaders at 2005 Excellence in Patient Safety, which is so needed in this environment. Really anxious to have you share what you've heard and help us understand how this transition has happened. I'll give it over to you, Dr.
Thank you, Carol, and thank you, the Canadian Association of Retired Persons, for giving us this opportunity to showcase our work. I hope you're able to see the slides. I'll just pull it into share mode. You're able to see my slides?
Yep.
All right, thank you so much. So Thanks again to CARP, and thank you all the presenters for this interest in this emotion-focused model of care as well. I'll go through a couple of slides today, and then we'll have opportunity to ask questions as we go through. So really today's presentation is to provide you folks an overview of the butterfly approach of care that we have done here at Osler, get some shared awareness and perhaps knowledge sharing with all the participants within this group and beyond. So that's really what we are hoping to achieve from today's presentation. But as we go forward, I wanted to just give you a sense of what Osler is about and what is the seniors health program here at Osler actually does. It's not just about the butterfly. I mean, we do much more than just the butterfly model of care. So if we look at every door that comes to Osler is the right door for a seniors who walks in. So I just wanted to put that out there so that we are trying to move ourselves to being more of a seniors friendly hospital or an age friendly health system as we evolve. So we're starting with some of the components there. If you look at it, then the emerge, we have geriatric emergency nurses who help screen older adults when they first show up. In our EDs, we have an inpatient unit, which is the acute care of the elderly unit. And this is the unit which really has the butterfly model that we will delve a little more into details about. We have some cross-corporate teams. Our behavioral intervention teams actually assess behaviors for patients across the organization, whether they're at the Brampton Civic site or the Etobicoke General site. We also have teams in our ambulatory site at Peel and also in our EDs, both at our Peel site and our two emergers at BCH and EGH as well. Our geriatric consultation liaison team is a team of geriatricians and a nurse practitioner who go out and see patients that might be on a medical surgical unit that require help and might be an older adult struggling with any of the geriatric syndromes. We have a hospital elder life program. It's a team of volunteers that work within our hospital and work within our volunteer services here at Osler as well, who help to define what might be activities to prevent delirium or sundowning in patients that are admitted in our inpatient units as well. So that's a big shout out to our volunteer teams who help us with our help program as well. We also have some ambulatory services. So in terms of geriatric outreach teams that go out into patients' home with a geriatrician, we partner with the Peel paramedic community to look at community paramedics. So these are paramedics who actually go into homes to do an assessment, and they liaise with our geriatricians as well with our medical director. We have also partnered with the region of Peel, and Dr. Saha, who is our medical director attached to our program, is also the medical director at the region of Peel. And we have developed some units called the Transitional Behavioral Support Unit, which are also transitional units. These are behavioral support units in the community before a patient transitions to long-term care. So you can see across the continuum of care, right from the emerge back into the community itself, how geriatric services are interwoven at various levels within our four walls. Our ambulatory clinics, we are in a unique position here at Osler to have a number of subspecialty clinics, whether it's the memory clinic, the neuro rehab clinic, the falls frailty clinic. So all of these clinics really see patients targeting geriatric syndromes that an older adult may be struggling with. So I really wanted to sort of put that into context in terms of what the seniors program is actually offering here at Osler. Clearly, as we are trying to drive quality and excellence, our butterfly emotion-focused model of care is something that we are really proud of, and that's something that we have been able to, thanks to our medical director and our leadership team, senior leadership teams here at Osler, who has supported this work to drive this change going forward. We also do geriatric assessments across the continuum of care, whether it was in the ED, whether it's the inpatient or the outpatient services. We've been recently involved in some work with specialized geriatric services with the Provincial Geriatric Leadership Organization, the PGLO, and also the Regional Geriatric Program to see what should be the basket of services we need to develop within this region, whether that's primary or secondary or tertiary level of services for older adult. Thanks to some recognition, Osler did award us with the Innovation Award when we won this in 2024. And as Carol just mentioned, we're really honored by the CCHL to receive the Patient Safety Excellence Award as well for 2025. And there's a ceremony happening in Edmonton coming June with regards to the CCHL award as well. We were recently featured in the Toronto Star for leading the way in dementia care. And again, Dr. Saha has been the champion with some of our butterfly focused model of care, bringing it here to Osler as we go forward. Now, we've been able to just bring some further evidence to some of our work. I mean, I'll just broadly touch on some of the themes in terms of research and academics our seniors health program is being focused on. Most of us are concerned with Alzheimer's disease, and we have actually partnered with DynaCare to sort of look at blood biomarkers for Alzheimer's. So Health Canada is still in the process of approving this, but I think it's very great that we have a partnership with DynaCare, so that we can actually, if somebody's concerned on saying, am I prone to Alzheimer's disease based on my family history, you actually now have a blood biomarker to determine whether that is suggestive or not suggestive of Alzheimer's. So, and that test is available here through Osler, thanks to our partnership with DynaCare. We have been involved in a number of, we've just launched the Osler Research Institute, and through that have been involved in a number of summer student research projects, one of which we were focusing particularly on the butterfly model that got published in the Canadian Geriatrics Journal and was also presented at the Canadian Conference on Dementia. We have been involved in some groundbreaking research. We are starting some new research with the National Institute of Health to look at how voice as a biomarker of health, because if there's some recent studies to show how voice modulation and how, as somebody ages, the voice could be as a biomarker to say, is it an early predictive sign of how someone's developing Alzheimer's disease based on just the modulation of voice. So this is using AI and voice, and so it's a new study that we'll be launching, in a number of sites across Canada are going to be taking part, and we are partnering with Mount Sinai here at William Osler. We're also launching some monoclonal antibody studies as well, so that our patient population have access to some drug trials to see treatment of hallucination and delusions that is associated with dementia. So these are new sort of monoclonal antibodies that can help treat these conditions in patients with older adults. So that's a new placebo-controlled trial. We are partnered with TMU, and thanks to Dr. Hussain and Dr. Saha, who are actually the medical directors of the geriatrics program here. So we will be able to get in a number of geriatricians to train the next generation of leaders in terms of the care of the elderly moving forward. But before we get to the model, I really wanted to bring a context on, who do we serve? And I think that's essentially, we need to know what's the patient population we're actually serving within our region. So for us, within the region of Peel, 15% of the total population are older adults, about 212, and this is as per the 2021 census. But this is not the number that really gets us worried. It's not that the fact that we serve 15% of the population, but that same 15% is actually going to grow by 56%, or actually has already grown by 56% in the last 10 years, and is projected to have a significant growth in the similar format. This is compared to the population of 15 to 64 that's growing only by 10%. So you can really see how there is a larger cohort of older adults coming into this region that all of us, whether we work in the community, whether we work in the hospital, need to serve the needs of this population itself. So when we also think about this population, it's also important to know frailty attached to an older adult. So actually, if you look within our region of Peel, you can see this incremental rise in number of cases of frailty. And what do I really mean by frailty is all of us, as we age, we have a reserve that prevents us from decline. So I think what happens when we get older, or when somebody is deemed as frail, they lose this that physiological reserve. And as a result, a cold really drowns us much more than it would have drowned us in our early years of our life as well. So as we lose this physiological reserve, that's something that's called frailty, and we assess for frailty in all our patients. Frail patients are 3 times more likely to be admitted to a hospital. They are 3 times more likely to stay longer than 30 days once admitted. They're also most likely to have significant health outcomes following an admission as well. So clearly, we need to identify frailty in these patients and try to see how we can prevent this happening in our older adults as we treat them. So when we think of our clinical risk profile, we kind of look at who are we serving within our population. And I'm going to skip through some of these younger cohorts of patients, because I want to go back to Fred, because this is the patient that we serve within our region. And this is a patient who has the highest clinical risk, has the most complex conditions. Most usually they have 5 or more chronic conditions. In this example, Fred is a patient here who is a retired 81-year-old with complex COPD, also with stroke, with diabetic pain, and also blood pressure and dementia. So you can see the complexity attached to this patient, and those are the nature of patients that the seniors program supports, and that the butterfly model would actually be supporting when in this case, for instance, Fred, who had dementia as well. So I'll take you down through a journey of one of our patients, and we have just created a misnomer attached to the name, but this is an actual patient who went through our hospital journey itself. So let's meet Kuljit. I mean, Kuljit is a patient who was staying in a retirement home. He was staying there for almost 2 months at the time when he came to us, and then got admitted through the emerge, basically because of violent and aggressive behavior. His wife was really concerned that she was absent in the care, and including the retirement home kept telling her not to be coming there because Kuljit was being very disruptive to her as well. In hospital A, where he got admitted, he got a lot of support, but at the same time, there were a number of code whites, and these are something we call when somebody is showing some kind of responsive behaviors. The patient was put on a number of times on restraints. They had a security assist all the time with him. He had a one-on-one sitter. So really, somebody sitting and observing you this way at all times of time really does not mean the best care. His wife really felt really disengaged. She felt there was a sitter there all the time. She was not able to really connect with Kuljit. And that was a time where one of this hospital actually sent out a call to our geriatric consultation service to see whether we could be involved in this patient's care. Following our consultation, we felt this was an appropriate admission to our ACE unit that I touched on earlier. And when this patient came on to the ACE, we had a different plan for Kuljit. We created an About Me poster where we got to know this patient. We also engaged the wife in the care attached to the approaches in managing the care. We, in fact, create a collaborative spirit where the patient and family member are together involved in the care that is being provided to them, including our clinicians as well, as a part of the behavioral improvements that we want to see. So with that, Kuljit really started showing behavioral improvements. He no longer required a sitter. There were no more code whites. We never ever had to put him on a restraint on our unit. We had fewer pharmacological needs in terms of medications that he required. And now this patient who was being declined from long-term care just because of his behavior now actually was well suited for long-term care, and then eventually transitioned to long-term care. So really paints you a picture of how the care journey of this patient who might be presenting with a retirement or any setting with a violent aggressive behavior, with the right approach or the right mix of ingredients can be looked at, and whether we can use the emotion focused model of care to define that. So when we think of the butterfly model, it's really being person-centered first. It is about Kuljit. It's about all the Kuljits that we might potentially meet, and what can we do in terms of defining care for this person that is person-centered, that is focused on his or her emotions, and also involving the family through that process. It's about looking at the holistic needs of the patient, trying to look at what interactive activities that they do, getting a sense of their cognitive status or what's their memory at a particular point in time, and then creating activities that are akin to their individualized needs as well. We were the first hospital in the world to be actually implement this butterfly model, though the butterfly model is out there in a couple of long-term care homes, also in the UK, but we are the first acute care hospital to have this implemented in an acute care setting. We've also received the highest level of accreditation, and just 3 years in a row, we have been the level 1 accredited hospital with regards to our butterfly model, and our most recent accreditation was in 2025. As you can see on the graph here on my right, essentially, we are seeing a large number of cases of dementia, and this number is really more than doubled in the last 10 years for us. So if you look at the last fiscal as of 24-25 Feb, we had close to 550 patients of dementia that were admitted into our hospital. So really, we need to do, what can we do for these patients? And I think you might have seen the sign about this color. And what is it about this color, about this butterfly that really amazes us? So I'm going to peel back a little just to get a sense of what is color and what does color mean to us in our lives itself. So if you look at the psychology of color, and this was published in the Journal of Neuropsychology, where there are studies to look at how color creates different emotions in all of us. If you look at yellows, we get a sense of feeling more happy and cheerful. If you look at greens, we get a sense of feeling more calming and relaxing. But at the same time, if you look at grays and blacks, I mean, you have a sense of you're being very serious and conservative, and in black, a sense of power control over one on the other. So it's really trying, and these are natural emotions that are elicited with us in terms of color itself. So how best can we use this color in our day-to-day lives? If you look at color and marketing, I mean, they definitely have used color in a big way. I mean, all of us look at our Kellogg's cereal in the mornings and we say, and it gives us a sense of excitement. It gets a sense of power and ambition, of activity and so forth. In terms of, if you look at if you go to a gas station on BP or see the Holiday Inn, you get a sense of being restorative, growth, and balance. And so, you could see in terms of the pinks giving a sense of a bit of nurture, a sense of care. So and these have been really well utilized, and you can see the various logos from various industries that have depicted those colors. And we might look at those colors and say, oh yeah, I recognize that MasterCard. I recognize that Tic Tac or that Starbucks logo, and that we've kind of branding colors based on that. So the question becomes, in healthcare, how do we take advantage of colors in terms of our care approaches as well? There's more to color than just. So I'll bring a little bit of the science behind the color as well, because neurotransmitters, or these are brain chemicals, play a large role in terms of controlling emotions within ourselves. So for instance, if you look at yellow, they release a neurotransmitter called serotonin. And one might be wondering, why does this emoji always is color yellow? And that's the reason I put that little emoji there, because it does create a sense of cheerfulness and happiness when you kind of see that emoji. And then you can see most of those emojis are yellow in color because they are releasing serotonin when we look at those emojis as well. We are also looking at a dopamine release when it gives a sense of when you see a color of an orange or a color of a green, which gives you a sense of a calming or a relaxing environment. So there are a number of, I've just put a couple of examples, but there's a whole slew of neurotransmitters here that we'll not get into the details to, but you have a broader sense of how different neurotransmitters interact in terms of creating a different emotional patterns within our brains. And how do we use that subtle color itself in terms of conducing an environment to help patients and families feel more supportive in their care. So with that, really trying to see, it's not just about color, but also about what else are we doing in the butterfly approach. So color is one, but it's also within the butterfly approach, the B usually stands for really being person-centered. It's not about doing things for something, but it's doing with somebody else. So it's not doing for, but it's doing with the patient. So I think we all our staff are trained on this approach to provide that level of care. They want to ensure that they are providing both emotional and physical stability for our patients. They want to do the tasks and they're not just looking at tasks being completed, but how do we elevate the moment at each time for that patient to be making that task meaningful? I think, and that's really important. Engaging number of teams in the care. So it's like we saw in that example with Kuljeet, how can we bring Kuljeet's wife in the care with the caregiver together in terms of what we needed to provide and what's important in that patient's role. It's really leading from someone's heart and by the hand. It's not really from the head. Not assuming that I know what is it. I know dementia, I know what I need to do, but each patient is different. Each heart is different. How do we move our hands in relation to that heart? So it's trying to create that emotional connection with our patients and families that drives the care for them. And I think those are just some aspects of the butterfly approach that we have inculcated in our acute care model here. So I touched a little earlier on the colors that we reflected on. So if you see the before effect of what our unit actually looked like, there were a lot of grays. You can see a little grays down there. as well. But we wanted to get a better sense of how we can repurpose this units to bring in the color based on the color neuropsychological science that we just reviewed. The greens make an area more inviting. So I think we have got our greens more into the hallways where patient rooms are, where it invites patients to go into their rooms rather than trying to exit seek in many of these areas. The pinks, as we said in the previous slide, shows a sense of nurture, shows a sense of care. And so where we have common areas where patients interact with nursing staff, those areas are generally colored pink. So you want this just intuitively brings down someone's blood pressure, brings it down aggression, allows for those care environments based on the neurochemicals that are released when somebody is actually seeing a pink color. But it's not just about the color. I touched a little about all the care approaches that we need to get to know the patient. I mean, all our patients have something called a getting to know me poster, where we get to know where they were born, where they were raised, and this is posted on their door. We get to know what their usual habits are, and we get the family and the patient to complete this together. So because sometimes our family members are the biggest, the most valuable historians for us. They are our eyes and ears of their loved ones at the home, and they bring that knowledge to us in terms of their care. So what do they like? What do they dislike? So that we can cater our approaches to them based on these personalized getting to know me posters. We also have had all our staff, including myself, complete one of these. So because we need to know as staff ourselves when we interact with each other, what does one person like about me and what does this person dislike about me as well. So that we get to know staff, get to know each other through these posters, and also our patients through these posters as well. Our units are preferably designed in smaller cohorts. So these hallways are uniquely colored, and so they have about 10 to 12 beds that we call the neighborhood units. And most of our staff are trained on a number of approaches like the GPA. We have all of them trained on the butterfly approach to care as well, and we could do something called a disc profile, so we get better sense of what are some of the attributes that the staff bring to their workplace, and so that we can tap on in terms of the care environment. Each of our hallways have these interactive codes, so that, when a patient is actually walking by, we can speak to them saying, why don't you pick this pear and put it into the basket? So they would have to differentiate between a pear on this tree and an apple on this tree. So that way, and those are some of those nominal words that we also use in cognitive assessment. So this, in a sense, act as a cognitive rehab area where you are actually asking somebody to pick 3 apples. So that really has a hand-eye coordination task. It has a task of remembering that I've asked somebody to pick 3 apples, somebody to learn that they differentiate between an apple and a pear. So all of these are subtle tasks that are then, and a number of cognitive processes are involved in that task. But using these in such interactive codes help us with cognitive rehab and also engage the patients in the right format. It's not creating just one kind of thing I just picked up on the fruit, but it could be looking at a vegetable basket, could be someone who's more likely to pick up flowers and create a flower arrangement. So it's creating different ways to engage patients based on their likes and dislikes, and not just having one cookie cutter approach for everyone. I think that's critical in terms of ensuring that butterfly approach. We are trying to get to make sure that we have engagement activities from our patients and their families. So at the end of every shift, we have these butterfly Kanban cards, so somebody can tell us whether they scored a 5 butterflies or we really scored a 1 butterfly at the end of the day. We also have visual cues from the patient as to what they liked or disliked, so that we can learn and tweak ourselves in terms of our actions. So we get that real-time feedback from our patient at the end of each shift. Because if we don't know what worked and what didn't work, we really cannot change the next experience for the next shift. So I think we use that feedback to improve our care on a day-to-day basis as well, shift to shift, time to time. We have been able to, with this model, really been bringing down a number of falls. You could see a 17% decrease in our falls, an 8% decrease in our kicking behaviors, also a 17% decrease in screaming behaviors. I touched a little on the pharmacological approaches that we did last time in a previous slide. But if you go a little into the details of, we are actually seeing post-butterfly unit a decrease in the use of antipsychotic medications and also a decrease in the use of PRN medications. So these are somebody who's showing us sudden responsive behavior, and you find there's a decrease in those as well. So clearly we are being able to demonstrate some improved standards of care in terms of quality improvement outcomes. And it's not just patient outcomes, we'll get a little more detail into that, but our own staff in terms of a patient safety culture survey that we did pre and post feel that we are able to provide better care in our units, and that and staff feel they are more safe in provision of those care itself. So that's really our valued strength, because our staff are our biggest asset, and we want to make sure that our staff feel the change that they are doing in terms of the care of their patients as well. So if you look at, I'm going to go a little deeper into some of the outcome indicators that we reflected on. So these were some of our behavioral indicators that we showed pre and post. We had compared our butterfly unit to a general medical unit to get a sense of our patients actually doing better in a butterfly unit versus a general medical unit. And you can see in all these, the blue bar representing the butterfly unit. In most of the areas, we have lesser delusions, we have lesser hallucinations, we have lesser disinhibited behavior, lesser irritability. So all of these areas, and these are a number of domains that we checked on to see our patients doing better. Those little two dots show that they were statistically significant, but I'll just stay away from statistics for now. But it just gives a sense of how most of our patients are actually doing better on our butterfly unit if you look at all of these behaviors. And it's not just about patients. We really wanted to get a sense of, it's great for us to say that your patient is doing better, but what about the caregiver who has to take this patient home? What about that loved one? What about Kuljit's wife when she gets him home? Did Kuljit's wife feel that someone's anxiety got better in a butterfly unit versus when she was on a general medical unit? So we've done this across around 100 patients, and we were studying them across these two units, two cohorts of patients that we studied. And you can see here that the blue again is lower in all of these domains compared to the orange, meaning and good validity in some of the areas, where it's really showing that our caregivers' stress scores are much significantly lower on our butterfly unit compared to our general medical unit at the point of discharge. So clearly, again, demonstrating that the butterfly emotion-focused model of care really helps both the caregiver and also the patient in terms of their care outcomes. We did publish this work at the Canadian Conference of Dementia. So this is just a poster that we shared at that conference. And we also are having a publication coming up in a manuscript in a Canadian Geriatrics Journal. I think that's going to be published later this year. I'm happy to share that reference so that you have an opportunity to read through the full paper. But it just gives a validation of some of the work that the team has done in terms of demonstrating these behaviors. And we got a little deeper into these slides just in terms of the matched cohorts that I shared some time back. And just in terms of our final slide, I think we are, thanks to our senior team here at Osler, we are, right now we have an ACE unit on our BCH site at our Brampton Civic site. We are looking to scale and spread that to our Etobicoke General site, so that at our sister hospital at Etobicoke, so that both patients coming to Brampton Civic and Etobicoke have access to this model of care. So that's something we will be looking to do shortly. We have already done our comparative models that I showed you with medicine, but some work is away too, because we have a couple of region of Peel homes that are currently now following the butterfly model of care. So we are trying to see whether we can get some comparative models with long-term care to see what is the butterfly model of care in a long-term care look like compared to our acute care setting as well. We have just partnered with the Toronto Medical School, so the TMU and Toronto Metropolitan University, and I think with this our partnership with the School of Medicine, we are looking to get in about 6 geriatric fellows, and I think with these new learners coming into our program, we'll kind of formulate even future learning opportunities as to how we can evolve this model and publish regarding some of this work and share some of the successes as well. We are really looking to advance the thought leadership in this model. I think thanks to CARP and other organizations that are reaching out to say, what's the buzz with regards to this emotion-focused model of care, and how can we really affect outcomes for our patients? So I think collectively raising this awareness within our communities, also with other hospitals and other partners, we'll be able to provide better care for dementia patients till we wait for the next big thing, which would be the monoclonal antibodies that would be disease-modifying agents that are coming to. They're currently in research trials, but will be coming to Canada soon. So with that, I'll conclude my presentation. Happy to take any questions. I'll turn it back to Carol.
Thank you so much, Dr. Nadkarni. Maybe you could, oh, perfect, wonderful. I just wanted to say that when you started out and you explained a little bit about what Osler's doing, it was very impressive in terms of your programs, your research, and your academics and so on. It's really quite amazing what you're doing. And we did have, a question, ACE standing for Acute Care of the Elderly. So maybe we just start at the basics, and then as people are lining up their questions, we can carry on. But basically what you're doing is assessing, are you not? Is it more of an assessment, behavioral assessment, cognitive assessment area in the hospital? Or how would you define ACE?
So ACE is, as you rightly said, is the acute care of the elderly unit. So we have patients who have complex geriatric syndromes. So it's not just somebody presenting with just dementia. It may be dementia with hypertension, with COPD, with pulmonary embolism. So we have a number of clinical conditions coming together. If it was one straight diagnosis, they would have been treated on a general medical unit. But now when we have complexity attached to these patients, like you saw that little pyramid where we shared right on the top was Fred with 6 or more conditions. This is a little more complex, and you have multiple interactions there on 10 or more medications. So there's much more complexity attached to the care. That's when they come to an acute care of the elderly unit, where you are able to have geriatricians who have the expertise who look at these complex syndromes. Not every patient needs to come to ACE, because that's that's a misnomer out there saying, oh, we don't have an ACE unit, I may not get the right care. No, it's not about that. It's about, do I have the complexity attached to get to an ACE unit to begin with? So, but when we look at when they come to an ACE unit, yes, a large portion of those patients are dementia, but they also have other complex geriatric syndromes that may be comorbid with them.
Okay. So the average length of stay for someone who comes to the ACE unit would be how long, would you say?
It's about 15 to 20 days, because yes, it's not so compared to a general acute medicine unit, which is about 5 to 7. So yes, we are much longer, 15 to 20, almost double, 3 times that of a general medicine unit. But we are dealing with much more complexity we were painting the picture on. So it's not about treating one condition, it's trying to creating the whole person as they transition back to the community.
So would most transition back to the community, or what percentage would end up going to long-term care, do you think, I guess is really my question.
Yeah, we've been having mixed results with where patients go. Some of our patients are actually going back home, like in Kuljit's, that example that we shared, they went to long-term care, but we also had patients going back to their retirement home, going back with their loved ones. So I think a rough mix is about 40% of our patients are currently going to long-term care. Others are going to other care settings, predominantly home and retirement, because it's trying to look at not every patient needs to get to a long-term care setting. So if we can support patients in terms of their behavioral patterns, teaching them approaches in terms of care, they're better able to take care of their loved ones. None of us would always like to age at home, because home is the safest place for us. And I think it's always best to see how we can enable caregivers to get them back. Osler also has some other programs. I mean, we have a Bayshore at Home program as well to support patients at home. We have an Osler at Home program where we are looking at adding some supports to the patients. So our transitional care coordinators who support these discharges enable some of these supports for caregivers so that we can customize those approaches for patients as they transition.
Right. It's so important, because so oftentimes what happens is caregivers can't manage their loved one at home, and so hence hospital and so on. And so it's wonderful that they're given a path, they're given a way in which to manage this, and they're part of the care plan and taught how to manage and deal with them so they can go home. So I think that's really quite exciting. How long have you been the program director at ACE?
I've been in this role for about 2.5 years now. I think it's been great learnings for me as I got onto the model. I think Dr. Saha introduced this, who I touched on earlier, is the medical director for the program. He's someone who actually spearheaded that, bringing that here to Osler as the geriatrician. I've been involved in terms of doing an evaluation of that model largely because, yeah, we are hearing this at the bedside, we're hearing it from patients and families, but it's not that single voice cannot be amplified. And how can we amplify the voice with evidence? I think that's something I'm trying to enable to get that to the next level so that we can bring in some research studies to define how we can create and show these outcomes to a broader community to say how this has really worked within our settings.
We need that for sure as we can move forward. So I guess you didn't really start this butterfly program, but what was the impetus for doing it then at Osler? How did it come about?
I think I touched a little on the number of, I showed a little graph there, 10 years on how our number of patients with dementia is actually coming to our unit, right? So we have a large number of patients coming to dementia. Dr. Saha actually comes to us trained in the UK, had some knowledge about the butterfly model there in the UK as well. Given this, we were seeing that we were not able to create a dent in terms of the outcomes attached to our dementia patients. Like you rightly pointed out, most of our patients are going to long-term care. Our caregiver stress levels are significantly high. So when we are seeing these concerns, how can we make these concerns into an opportunity? So what seemed to be a problem for us, we thought, let's flip that around and make that an opportunity. And what can we do in terms of models out there that we can bring to define care for us? We've also, in our region, worked closely with families in terms of providing the care. Just at Osler, we generally do that in terms of our essential care partners that we had here at Osler during the pandemic and before. So I think we really felt, how can we engage patients and families in terms of the right care model? So keeping some of these guiding principles really brought us to think about the butterfly model. I mean, it is being used in the UK with the NHS in a number of settings as well. This was also in Australia, a couple of units, again, mainly in long-term care, have been using this model. So for us, it was trying to say, can we take aspects of that model and bring that into an acute care? It did require a leap of faith, and thanks to our senior team as well, who trusted the leadership within the program to say, yes, let's take that leap of faith and let's see how we can define that in terms of emotional focused care here at Osler. And I think it's great to have the support of leadership to drive that, but what are our outcomes? Are we able to see changes in our patients and families? Are we able to keep that consistent in over year? And yes, 3 years in a row, we've been able to demonstrate the highest level as with level 1 accreditation. And now we are actually going further to show some thought leadership to say, is there evidence that peer-reviewed articles or posters at conferences that we have presented, that our peers are looking at this data and saying, yes, there's some validation to your numbers, not just you saying it, the data science proves it as well.
That's great. Now, you talked about staff and you showed a slide about staffing there, the one in the middle, in terms of how they feel safer and so on. Satisfaction. Do you find the staff happier than working for you? Is there any evaluation data there that says, oh, we have less staff turnover, or people want to work at ACE, they don't want to work somewhere else?
I'm glad you brought that up, Margaret, because yeah, we have done some staff engagement scores are definitely going much higher. Our retention and our turnover rates have actually gone down. We have higher retention rates. In fact, staff are looking to come to work here at Osler. We also find within our seniors health program that staff feel more engaged. I mean, I had a slide which I didn't bring up, is to say, what are staff's responses following the care as well, right? So because they are emotionally involved in the care journey of the patients they take care of, and so are patients who feel connected with the staff. So I think it creates that broader caring community around them. So I think that's really critical, as these are staff members who go back into our communities and who will be living members of our society. So we learn to recognize both patients' cognition and aging in our communities as well. So there's broader refurbishments from that. So as we take this emotional model of care, not just at the bedside, we take it back to our communities. We look at an older adult who's walking to cross the street or cross the sidewalk. We may be a little more responsive citizens of our community as well going forward. So I think these are values as we take broader than just within what's happening within the unit. And I think some are measurable, some anecdotal, which really helps us in the long.
Good. And staff are trained. You mentioned that. So you have a training program. How long is it? What
So
are you?
a number of training initiatives brought for our staff. I mean, we have all our staff go through a general orientation from the hospital as well. We have something called the GPA that I touched on, the gentle persuasive approaches. We have the pieces training that is offered to all our staff. We have the meaningful emotional focused model of care. That's about that's a week training that they go into, where they're actually given simulated environments. So if somebody is struggling with cataract, we actually get them to wear glasses that see the refractions that a patient would be seeing. We might hold their arms to say, somebody is struggling with severe arthritis, what would the fingers actually look like? So we might hold up 3 arms, saying, now go hold this glass, and what do you actually feel like when you're holding the glass? So that patients and families both feel and understand how they are actually taking care of someone's needs, and they do that in simulated environments so that before you go and face yourself in front of a patient. We are also fortunate to be a niche organization. So the Center for the Care of the Elderly, which comes from the US. So we have a niche designation, and we have a number of modules on that niche site that our staff go through in terms of understanding the different geriatric syndromes, whether it is depression, whether it's dementia, so that they are getting knowledge about some of those pieces. So those are all critical training components that our staff get in. Obviously, when they come in as RN and RPNs, PSWs or healthcare aides, all of them, whether regulated or unregulated, would be going through screenings and get additional training to help them with these skills on the floor.
Okay, that's good. And in order to put in the butterfly model into your unit, it took some funding, no doubt. Was that an issue? And where did it come from?
Yes, I mean, again, a big shout out to our senior team here at Osler who took that big leap of faith on us, because yes, it did require a significant amount of investment. You saw, I showed you the before and after colors, but it's not about just paint. It's also about staff. It's also about training. It's ongoing support on a day-to-day in terms of what are the educational needs of staff as we evolve. So again, the leadership here has been fully supportive of these initiatives. And I think that at the end of the day, it shows in terms of the results that we are able to demonstrate for our patients. So I think it's really critical. If you put that in terms of missed opportunity cost, what is the cost of a fall that a patient might get through? What do we look at dementia outcomes that are poor, which result in multiple readmissions attached to our patients? And these are things that we are able to stem down. And lesser use of antipsychotics would mean lesser side effects. Those are coming from those antipsychotics, which is also reduce opportunity costs attached to some of those things. So there may be more work down the line to say how the butterfly model or emotion-focused model of care actually reduces cost per patient day. I mean, that may be something that we might evolve in over a period of time, as we have seen anecdotally, lesser antipsychotic use, lesser falls, lesser use of restraints. All of these come to us at cost. One-to-one sitters come to us at significant costs. And if all of these costs are right now being brought down just based on what our outcome data shows, obviously the cost data would have to follow that as well. But you raise a good point, or perhaps sparked me on a tangential thought of what my next research topic could be. So thanks.
Thank you. Because I think as we go down the road and look at long-term care more specifically in terms of models of care, that certainly is one area that we need to focus more research on, I think, because the outcome of, it costs money to do it in the beginning, but then towards the 2-year period, I believe what we found is that the costs are recuperated with less staff turnover, less drugs use, and so on and so forth. It would be good to have the research data to confirm that, even though the staff are telling us that. So it would be nice to do that. So please do that research. Well, I found it interesting with your interactive coves going to your slides. So were those knobs underneath the picture where they'd actually pick the 3 apples and pick the 3 pears? I was trying to figure out how I would do that. So are they actually doing that on the wall, or how does that work?
Yes, they are magnetically attached to the wall. We've got IPAC approval in terms of the surfaces so that they can be cleaned and wiped in terms of an IPAC IPAC requirement or infection prevention control requirement as well. I think the idea is really looking at cognitive rehab. I mean, that's what we are trying to do rather than having plain hallways that somebody just walks through. Those coves allows us an opportunity to stop. It allows us an opportunity to interact. It allows us an opportunity to engage a patient, a family, a member with simple tasks, but there is science behind those tasks. So as somebody just said, pick 3 apples and put that in a basket. I mean, yes, any caregiver can engage their loved one in that task. But what are we doing with the simple task is we are looking at 3 processes within our brain. We are looking, can I remember the number 3, which is really important to know. Can I differentiate an apple from a pear? That's another important piece to know. Do I have the hand-eye coordination? So you're actually looking at your frontal lobe, your limbic system, your occipital lobes, and you're actually stimulating each of these in terms of trying to get to that task. So what we take for granted in our day-to-day lives, somebody who's struggling with cognitive impairment is really trying to process these in their own ways. And I think trying to engage them through some meaningful tasks where a patient and a family is also connected with them, because maybe I don't like an apple, I really like pears, and that's why I might go to a pear, and that's maybe a better place for me to go and pick fruit rather than being disruptive about some fruit that I didn't like or I had a poor memory about or an emotional connection with. So I think these are aspects that we are able to engage our loved ones and our families in some of these interactions. There have been studies in the digital world with cognitive rehab tools as well. So yes, right now we might, as we spread into our new Peel site, we might even look at in the future world looking at digital cognitive rehab as well, so that we can look at different digital processing, so that when we look at AI and other technology to say how we can look at replacing that fruit with a digital screen as we are pulling out fruits. And there are already centers like the UCLA in the US that already are currently doing that in their inpatient settings. So it's a lot for us to learn and mirror from what rest of the world is doing in terms of advancement in dementia care.
Yeah, I thought that was interesting because I have been in a number of Butterfly long-term care homes where there's lovely pictures on the walls, but here's an interactive wall as you walk down, which I thought that's very interesting.
And those interactions engage emotional memories, right? I think it's really critical for us to engage those emotional memories. I touched a little on those serotonin, those neurotransmitters that are released, and those neurotransmitters really help create those chemical connections in our brain that we all need on a day-to-day basis. So it's not just about the splash of the color, it's not just about the painting, but how do we interact with that environment to make that our own, and engage patients and families in that interaction as well. So that way it doesn't always have to be a nurse showing you to take those 3 apples. That's a simple task that any one of us could do with our loved one. And it also gives some meaningful activities for the son or a family member who has come, who doesn't really know how to interact with dad, who I have not seen for a while, or I just happen to be visiting once in 2 months, and now it turns out my dad is in the hospital. How do I interact? What do I say? Here's a simple activity saying, just engage, pull up some fruits from the tree, and any one of us could do that. It opens up conversations, and I think those are things that creates those connections for both the family and for the loved one as well.
When you and I chatted previously, when we were talking about setting up this webinar, you said a phrase to me, which I've been thinking about, and maybe you can expand on it, which I kind of liked. You said walls should not define us. Can you sort of expound on that? I think that was very intuitive what you said.
No, I mean, I was reflecting on the fact that, we're all bound by structure in our life. I mean, we are bound by our shifts on the day. We are bound by the environment that we work with. But I think the question is, are we keeping those walls to bound us in terms of our environment, and whether we are limiting our reach to the outer world? So it's the same wall. If we have created an interactive cove with that wall, yes, I'm not looking at the wall now. I'm looking at a garden that perhaps, or a flute yard where I have really not had a chance to be in my condition. So how do I make that wall interactive for me, whether it's digital, whether it is this taking out this little magnetic piece on that. So this would be in terms of structure within programs that we have, but also looking at walls more virtually. Let's not look at just care within the settings of the hospital itself. You touched on what's happening in long-term care, and we are fortunate within our region to partner with 5 long-term care homes within the region of Peel, so that to say, what does care for dementia patients look outside the wall of the hospital? And I touched on the fact that, yes, we have paramedics going into patients' homes. We have our own teams going to patients' homes. So let's take those care approaches and learnings outside the four walls of the hospital to see what does broader community look like. There are models like in Netherlands who have actually created age-friendly communities as well. I mean, why stop short there? Why can't we be an age-friendly community here in Brampton? And I'm speaking selfishly for Brampton because Osler is in Brampton and I'm a resident of the city, but it could be any city for that matter, right? So I think, how do we champion some of those with our city, with our other community partners? So let's not not bound our thinking, and let's not bound our action. So I think that's what I was really reflecting on, to say, focus. We are all going to age, whether we like it or not. That's a part of our natural journey of life. Let's try to see how we can enable functionality across the journey to make it a better experience for everyone going forward.
And there is a question up there. How do you use the DISC profile?
Yeah, so I didn't delve deeper into the DISC profile, but the DISC profile gives us it's a chart where you're asked about 300 questions. So you get a better sense on how does this person think? Is this person emotionally inclined? Is this person more directive? Is this person softer in their approaches? So we needed to get and all of our care teams go through these DISC profiles, so that we want to get a sense of how is this person's interaction with somebody else. It's only when we know someone's how they interact with each other are we better able to connect with each other. So when you go into a room with a number of people, you're naturally inclined to one or the other person perhaps making a visual cue. That may not be something we can do in a care environment where you always are going to be connecting with a patient. So in that sense, we want to make sure that our staff have the necessary skills. They also know themselves to say, am I inclined to these kind of behaviors, and what should I be doing to check myself if I'm being too directive, if I'm too overpowering. And so that way we can use these to guide our own actions in terms of a care environment. So the DISC profile is something that we do annually, so that we get a profile of what our DISC looks like and what should be a DISC that means that supports an emotional focus model of care as well, so that we understand ourselves to see what behaviors we might want to adapt to help our patients and our families, support them in their care journeys.
Well, the bewitching hour is here, and I've thoroughly enjoyed listening to you, Dr. Nadkarni, and you're doing amazing work there at Osler, and I wish you well as you advocate to other hospitals. And we certainly are advocating in long-term care, but we can see where that needs to move out even further, and walls should not define us. So thank you so much for spending time with us today. And I'll now turn it over to Taeyun.
Thank you so much, Carol. Yeah, thank you so much, Dr. Nadkarni, for this wonderful presentation and all your expertise. And of course, to our co-host, Carp Ottawa, Carol and Margaret, for helping out with today's webinar. And also just to everybody being so engaging and present. We always really value everyone's participation and your questions. And we've had a few events with CARP this season, and we're going to have a lot more in the fall. So we're really excited to continue doing our work. And I also want to just take a moment to mention that Family Council Ontario is hosting a conference in a month, the second week of June. It's going to be a hybrid conference. So taking place in Hamilton and also online on June 11 and June 12th. It's called Connecting Through Care, Creating Champions. All the information is on Family Council's Ontario website. So I encourage you to go and check it out if you can attend in person, or we also have all the programming online as well. And as a reminder, this webinar has been recorded and it will be made available on our YouTube channel next week. So you can view it again and you can share it with folks that maybe weren't present today. Thank you so much, everybody. Please make sure to subscribe to our e-bulletin as well if you want to keep in touch with all of our events and projects. And I wish you a good rest of the day. Thank you, everyone.
Thank you.
Thank you. Goodbye.